We are good.
Welcome everyone. Thank you for coming. My name is Haley. I'm a second-year medical student for those of you that don't know me. And thanks to a lot of the CMDA doctors and nurses and community members who are here as well. And I also wanted to introduce John. He's here from Students for Life. He's the Northwest Regional Director. And thank him for coming, and thank the National Executive Office as well for supporting us and helping us get this panel together. So we're really excited. John?
Yeah, just wanted to let you know we are here to help you guys with your patient care. This is going to be a huge aspect of what you're going to do when you become physicians, and just wanted to let you know that we are here to support you. We will provide you with materials. We also have externship programs we offer, medical lectures, as well as spring tours and fall tours where we bring physicians from throughout the country through your area, and hopefully we can bring one here to OHSU in the fall. And so just wanted to say thank you for allowing me to be here, and anything that we can do. We also, for your convenience too, if you ever run into an issue along these ethical lines, we do have a great relationship with Alliance Defense Fund, who will represent you from a legal standpoint. So know that you are cared for, and that if there's any needs that you guys have, we are here for you. We're here to support you. We have a sign-up sheet if you're interested. We want to get an actual Med Students for Life group going here on campus. We understand that there is a Med Students for Choice group. We feel like there needs to be a counterbalance to that. So if you guys are interested today, please sign up, and I'll be in contact with you, and we'll get things rolling to make it official. Thank you.
All right, so now on to our panel. Down on the far end, we have Dr. Havila DeBell. Hi. And here in the center, we have Dr. Bill Toffler.
Hello.
And closest to me, Dr. Angela Larson. So Havila, let's start with you. Just kind of introduce yourself. Tell us a little bit about your medical training and background, and kind of what got you passionate about the issue.
Okay. I'm Havila DeBell, and I just finished my residency last summer. I trained in Vancouver, Washington, and I completed my family medicine residency. And during my residency, I had the opportunity to do a lot of obstetrics care, so a lot of prenatal care and labor and delivery. And I also had, lots of just regular clinic because it's family practice, and so I had a lot of patients who had unplanned pregnancy, or counseling them about reproductive health. And so I really got interested and inspired by just different patients I met and experiences I had with learning how to talk to them about the issues around reproductive health. And so now I'm working a couple jobs. One is at an urgent care, and so I have a lot of patient encounters there with newly discovered pregnancy and that first stage. And also I'm doing some primary care as well, and in that setting definitely come across women who are facing choices that surround early parts of pregnancy. So something that I think about a lot, pray about a lot, and just experience a lot with different patients that I take care of.
Dr. Toffler?
Sure. Well, I just can't tell you how excited I am to be here, because I've been here for over a quarter century at OHSU as now I'm a professor. Started in Oregon, in a small town, Sweet Home, 2 hours south of here in the foothills of the Cascades, for 6 years before I came here. But heretofore, there'd never been any session like this that's occurred, to my knowledge, where we actually talked about a counterpoint, as John put it, to the so-called medical students for choice. And I am very deeply enmeshed in life issues, both here in Oregon. I'm the National Director for Physicians for Compassionate Care, trying to maintain a consistent ethic of affirming the inherent value of human life at the end of life. And I just spoke probably for the 25th year in a row at the Oregon Right to Life meeting that was held at the Airport Holiday Inn And it's a privilege to go there every year and meet with other national leaders in their respective areas, giving a flavor of the extent of this issue. The opening talk was from a lawyer who spoke about the forced one-child policy in China and her full-time efforts to try to speak up for human rights and the rights of women, and truly an organization for women that she's formed in allowing choice from a life issue. And it closed with a speech talk by one of the two most inspirational leaders, I think, in the whole effort to protect the inherent value of all human life from conception and natural death, was by Sean Carney, who's one of the co-founders of 40 Days for Life. I don't know how many of you are familiar with that, but it didn't exist a decade ago. And there's a tremendous amount of conversion of heart that now goes on with peaceful, prayerful protests against abortion in all 50 states and at least a half dozen countries. And it's had a huge impact on converting hearts, even of people who work in the abortion centers. But most importantly, I think why I'm excited to be here is that, you know, when I was a medical student, I made some very bad choices. And I was trying to blend in, and I think I would regret some of the choices, and I'll be glad to share some of those this evening. And I would be somewhat, you know, reluctant to want to talk about those things. They're not really things I look back with any sort of anything except for regret. On the other hand, I'm excited to share them because I don't want other people to not be clear about not parking your integrity by the door in your training and in your life. And that's critical. In fact, it's become more important now at a national level, international level, as our own religious freedom to be open with whatever your religious background is really threatened. And we can talk about those things as well. But it's just exciting to have an opportunity at OHSU, in an OHSU building, to actually talk about things that Angela and Havila and I get to share with you.
Dr. Larson. So I'm Angela Larson, and I graduated from OHSU in 2010, and I'm currently a second-year resident at Family Medicine of Southwest Washington in Vancouver, and so Havila is 2 years above me. And so I probably got interested in this issue from long before medical school, but more on the periphery. And then when I entered medical school, I was heavily involved in CMDA. And through CMDA, I found people that really inspired me to provide patient care in a way that is so loving and maintaining to integrity and maintaining the principles that we share regarding our faith. And all those people really inspired me to try to provide patient care in a way that was so that other people wouldn't be able to look at me and say, you know, you're just one of those people who hold signs and, you know, hate people. You know, actually learn to provide patient care around this issue in a compassionate way. And there's lots of people that I met during medical school that inspired me. So that's what I'm hoping to do tonight, is just share some of the things that I've learned about talking to patients around this issue and doing it in a compassionate way, so that when people look at your work and people look at your care, they can't find any fault with it because you're loving the patient.
All right, well, let's start with kind of a broad question for the panel. So I'm in your office for a pregnancy test, and you ask me what I'll do if it's positive, and I say I'll abort. What do you do as a physician, or perhaps as a medical student?
So actually, it's interesting. I just had this experience on Friday. One of my patients came with flu symptoms, and I asked her before we did any testing if there's a chance that she could be pregnant, and she said yes. And that's really when the dialogue gets started. I mean, of course, it's even before in your mannerisms in meeting the patient from the very beginning. But the most important thing, I think, is setting the groundwork for having the patient feel comfortable with telling you that very thing. You don't want them to be hesitant or afraid, because you need to have that trust in the relationship, so you can talk to them about how you feel or advice that you might have, without it seeming as though they are gonna have to be listening to you but maybe not present. So basically I just said, how would you feel if you were pregnant? I didn't even ask, what are your thoughts on what you would do? So I think that's important too, in the way you phrase it, because we are in a culture now where it's like you have a choice for what you would quote unquote do. And so actually I just don't even like to use those terms, and have the person kind of speak what they're feeling. That's really important, is to get that sense of how they're feeling. What she said she was feeling is afraid, and that she wanted to just not deal with it, and she wanted to have an abortion if she was pregnant. So the second thing I asked her was just if she knew anybody who had had that experience, because that's really important. A lot of times people base their decisions on what they've seen. I mean, you can meet with your patient and have a good relationship with them, but really, they have their life. Most of their hours are not with you. They're with their peer group, or their partner, their family. And so it's important to find out what is influencing their choices. And maybe it's not much of anything. In this case, the patient had a relationship with a partner who she felt afraid of and didn't want to have that connection with anymore. And so that was her source of wanting to, quote unquote, not deal with it, is she didn't want to have the connection to the person anymore that she had become pregnant by. So that is important in assessing, where people's emotions are coming from, is why they want to, cover something up, or make that choice. And so for her, I just mostly focused on ways of getting support, and didn't even go into, do you think abortion is right or wrong? How could you, think of that? I didn't make any type of moral implication. I just talked to her about, wow, that must be a really scary thing to feel like you don't want to be thinking about this person anymore, and you have no one to turn to. Do you know about, different clinics? I mentioned different places that could offer her support, and I didn't even say, can offer you support to keep the baby or to do anything like that. I just said, that can be there for you through this time, because you don't want to put any type of, at least from my perspective, if you put any type of your own idea of what they should be doing, that's in a sense placing a judgment, I think, and I think it's important to not have someone feel like they're being judged. And so in her case, I just didn't try and cover all the points, about what do you think of abortion and this and that. Just assess, basically, to come back to the question, assess why the patient is thinking of abortion, what the underlying reason is, and just offer connection for that reason. So I feel like I'm talking a lot, so I'll pass it off to you, Bill.
Angela.
Or Angela.
It's particularly hard for you because you're in residency and you're out by yourself.
Right.
And
Yeah.
how about from a resident point of view?
So actually, the very first day of residency, or the very first time I was in clinic in residency, a woman came to me who had had multiple abortions, and came with a thing that she had a positive pregnancy test, and she wasn't sure what she wanted to do. And in this case, I think I did very similarly to Havilah, and that is to ask her how she's feeling about the pregnancy and try to offer support. And of course, as an intern, you have to precept every case. So you have to bring your case before an attending and explain what's going on. And that day, it happened to be one of the faculty in the precepting room who is very pro-choice, and Dr. Baker, who you guys know, was also in the presenting room, but I happened to sit down and be talking with the pro-choice attending. And I wanted to be as wise, but also careful, given that also my reputation and beginning residency was still out there. So I think I tried to be as guarded in some ways, and I don't know if that was good or not, but I tried to present it in a way that I was being open to the patient, that I was caring about the patient, that I was trying to provide her with support. And the preceptor responded with, well, do you need me to come in there and tell her about her options? And I politely declined and said that I felt comfortable doing that. And but I didn't tell him that I was going to tell her where she could get an abortion. And you may get to this question later about, do you refer if they absolutely want a place to go to? And for me, I personally feel that that information is widely available, and rarely does the patient need you to tell them where to get an abortion. So I didn't tell her that, but thankfully Dr. Baker kind of backed me up and said that some providers feel differently about this issue, and kind of supporting me in the fact that I was trying to just offer the patient resources. And I ended up going in there and just providing, for example, one of the pregnancy resource center numbers to her, which we'll probably talk about resources as well, but I felt like it was also another place where she could go and get support and process her questions. I think for me, I just totally echo what you said, that it's really important to find out how the patient feels, and also how those around her are feeling. If she has a partner that she hasn't told, or maybe she's a teenager, how would this person feel if they, if you decided to do this? And sometimes I do go into how do they feel, or what do they believe about abortion, or because a lot of patients have belief systems that they've grown up with, and what they are going to do is contradictory to what they kind of know in their heart. And so although it may be kind of stressful, this whole situation is stressful, and I think it's important to ask good questions that will help the patient come to realize this conflict that they're dealing with in themselves, potentially, if they've grown up with a particular belief system about abortion, and then also kind of asking them. Another thing that I would do would just be like, how would you feel what are the pros of getting an abortion, for example? What are the cons? And what are the pros of keeping the baby or keeping the pregnancy, and whether you adopt or keep the baby beyond that? And what are the cons of that? And just helping them kind of think through some of those things. Again, some of it may be more a patient that you have a relationship that you're able to go that deep with. Whereas, you already know their background, or you already have a relationship with them, versus maybe in an urgent care setting where you're meeting the patient for the first time. It's a little bit harder to go into those details.
So I'm astonished at the wisdom that Havilah and Angela have relative to what lack of wisdom I had at their gestation. So it's very heartening to me to see the insights that they've developed and touched on. The first is asking almost any question, how do you feel about things? It's open-ended question, it's PCM, it's what you need to be doing. And then you also want to come back, and when they tell you how they feel, is you you might want to get into exactly what you did and you found out is why you feel that way. And the data shows that 90 to 95% of women choose abortion because they feel like they have no choice. That's what the data shows in focus groups. So it's, if you care about the woman, you want to find out why she feels that way, and then that helps you understand what can you do to alleviate that pressure. So, one of the other mistakes that I made was, I remember when I first came to HSU, someone from a life organization called me up and asked because they were interested in finding out if I'm a pro-life doctor. And I remember them asking me, do I refer for abortions? Of course I answered I was a pro-life doctor, And I said, well, I try to talk them out of it. I try to do the kinds of things that were hinted at here by Haviland and Angela, because I really would prefer that people not feel pressured to choose that option. That's my heart of hearts. That's true. I have 2 patients when I have an obstetric patient, not 1. That's my own belief. And that's a scientific fact, by the way. So that is my orientation. So, but this is a savvy pro-life person calling me on the phone, and she held my voice, I guess, not my hand, to the phone, and said, but what if a person, I said I'd try to get them resources, pregnancy resource centers. They were called crisis pregnancy centers at the time. It really isn't a crisis, so they've changed the name to be resources, which is what they are. And I try to offer my services. I'll give them away for free if necessary, and I would, and did, and do. But she said, well, what if they still want to have an abortion? And I, at this point, I'm getting kind of irritated with the questions. But I said, well, I'm a doctor first, and I have to go ahead and, if that's what she wants, I refer her for abortion. And then I'll never forget her response was, we don't consider a doctor fully pro-life unless they don't refer for abortion. So I was irritated. We hung up politely, but I'm here telling you about this umpteen years later because I agree with her. And why do I agree with her when I was obviously behaviorally not agreeing with her at the time the phone call came in? Well, I was actually in urgent care at one time at Emma Jones Hall when we used to have urgent care there, and the last room on the left where you all do OSCEs now. And so I was in there with the nurse who was dedicated to urgent care at the time. Zoe was her name. I don't remember the patient's name, but I remember that vividly. She was in her mid-30s. She had had 3 abortions already. She'd had 3 pregnancies that delivered, and all those kids had taken away from her because she had seizures, she had drug abuse, and probably the withdrawal seizures, and she was on anticonvulsants, which are all teratogenic. And she came in finding out she was pregnant, and when she was, she wanted to have yet another abortion. So I did all the things that the savvy pro-life person on the phone said, what do you do? And I went through a litany of things I tried to do, and it was clear I was getting glazed over look from the patient, and she wanted to have an abortion. So I went out of the sliding doors there at that little wing of the clinic that you all know well, and I talked to the nurse, and I started saying, give a little background, 1 minute, or no, 1 sentence kind of picture of what's going on, and the next sentence was, could you, and she interrupted me and says, I'm sorry, I don't deal with that. And I'm taken back a little bit, and I said, well, and I started another sentence, and she said, again, I'm sorry, I don't deal with that. And I remember responding and telling her, well, I'm glad you speak up. I think it's important that you follow your principles, that you don't want to be involved. And as the words flowed out of my mouth, and I said, I respect that, and in fact, I actually agree with it. And I'm thinking, well, if she's doing it, standing up for her integrity, why am I not? So I did a little inventory, leaning against the wall, and went back in the room, having told her I was going to help her get the help she really doesn't need, because Angela said it well. There's lots of resources. You Google an A and the first hits come up, A, B, whatever. And they're all over. You really don't have to be involved in that. And so I went in and respectfully repeated the offer to help her in any way I could, but I talked to the nurse, and she really didn't want to be involved, and frankly, I couldn't either now that I think about it. So I'd be glad to help you in all the ways I've said. I'd be glad to help you get services. I'll give my own services away. And at that point, some other nurse who really didn't have the same inhibitions about being involved helped her. I put it help in quotes because if you really care about the risk benefits of this, and this is something that I've learned as I'm on the Breast Cancer Prevention Institute board. I was on a conference call with them this week, as I've learned about the studies involved, the non-reassuring data and the reassuring data. If you really want to get into that, that'd be a whole other hour of our time. And it's much more complex than the data around the benefits and risk of circumcision, which also takes quite a while. But the point is that to say that there are no implications from the safe, legal, and rare, not so rare, abortion is absolutely ignoring the science. And so I want you to know that you really don't make people healthier. And that's what many people, I'll be a minority voice here, crying in the wilderness, eating locusts here, saying these kind of things, but it's true. The science supports what I'm saying. From a psychological point of view, the British College of OBGYNs really wants people screened for depression when they choose abortion, because they felt they have no choice. They do feel often hopeless. They do feel hurting. And it's literally double the risk of death in 1 year with a finished study where you've got a closed population. If you look at people, mortality, not from the abortion, that's all-cause mortality, the big M, if you will, of the M&M. In pregnancy, we're all told, Parkland Hospital data in Texas and high-risk places, it's such a risky thing. And if you look at the same women who chose to carry the baby to term, you know about preeclampsia and seizures and high blood pressure and bleeding and all that kind of thing. So we know those women must have a higher risk of death, an RR that's higher than 1.0, right? Well, the finished study showed it was 0.5. And then if you care about other data, this Breast Cancer Prevention Institute with biochemists and breast surgeons on it, in addition to me, little family physician here in Portland, Oregon, the reality is that it's not reassuring to women who have abortions in terms of their lifetime risk of breast cancer. In general, it's about 30% higher. Certain risk groups, like if you're a teenager before you have the protective effect of a full-term pregnancy, it's 4 times higher lifetime risk. These are peer-reviewed studies that are not reassuring to women. And that's my point. If I tell people about prostate-specific antigen, I want to tell them the benefits, the risk. I want to tell them the USPSTF just came out and said the D rating. That's what we did. We should be telling people this. And so I don't do it in the initial conversation. I think Havilah said it very well. If you can just get them to help and you get them to come back, there really is no urgency. There is no crisis, if you will. People feel like there's a crisis, but feelings are not what we're talking about here. The woman is actually healthier by being pregnant. Did you know that? How is she healthier?
She gets medical care.
She gets medical care. I told you she has half the risk of dying than if she chose the other option. So if you take half versus double, that's actually a 4-fold difference. And what happens, what do you all know that nobody debates if the woman carries the baby in terms of her lifetime risk of breast cancer?
It's reduced.
It's reduced by 50%. So how are we helping her if we're believing that? And why what we're saying is so important is, and when you choose residency programs, I checked with my residency director because I knew we were going to have this panel. And if you were choosing OHSU Family Medicine or OHSU OBGYN, what are your expectations? Do you know? Well, I was really reassured that the residency director said that they did come down on the side of getting this so-called READY training, a grant funded to reproductive choices and options counseling. I'm always worried when I hear those words without any principles. But you have to opt in for that. You're not expected to do it. And just like Havilah, you are Angela, you were telling me you developed, which one of you two were telling me you developed an option for yourself to learn ultrasound? I think Angela.
Yeah, I did a rotation elective. So to back up, Southwest is more of an opt-in program. So if you want to do an elective in abortion training, you can, but if you don't want to, there's no pressure to do that. And so kind of as an alternative, I wanted to actually get more experience talking to women about this issue, you know, in those situations, because at this point, I mean, I'm learning to do OBGYN as well as family medicine in our program. And so I went there to learn to do some ultrasound and then also to just hear how these women who are counseling, you know, young teenagers and women in social disasters who come in with positive pregnancy tests, how are they talking to them? Because I wanted to get better at talking to patients about this challenging thing.
So you set up a rotation and you learned how to do ultrasound much better than when you started the rotation?
Absolutely, because it's early ultrasound.
Was it a 360 center? Is that what
yeah, it was at a pregnancy resource center.
Does everybody know what she's talking about? Well, you knew more than I did. I know what the 360 was. So.
Yeah, it's a kind of a, it's not a medical clinic, but it's a resource center that provides free pregnancy tests, and they also do limited ultrasounds to kind of verify pregnancies. And then beyond that, at these particular ones in Vancouver, they provide a lot of education, prenatal care, prenatal education. They help women you know, apply for insurance, find a doctor, and then throughout the pregnancy and even beyond, they have kind of almost these one-on-one classes where these like older, you know, kind of grandmotherly type women, you know, women who are experienced, some of whom have had abortions themselves and have gone through the kind of the trauma of that, who talk to women about, you know, their, they talk to them about their options, they talk to them about what barriers there are to keeping their pregnancy, keeping their baby. And interestingly enough, it's one of them is right next door to a Planned Parenthood. So they get a lot of women who come in and they thought they were going, you know, next door, but they ended up at the Option 360. So it was a really good experience to see the love that they expressed towards these women.
There are 5 pregnancy resource centers here in the metropolitan area. One of the executive director was at the Oregon Right to Life meeting yesterday, Larry Gadbaugh. And one of the OBGYNs that staffs the ultrasound and reviews the ultrasounds that they do at all the 5 centers, all of them are equipped with state-of-the-art ultrasounds. Focus on the Family has actually provided over 540 of these nationwide. Pregnancy resource centers outnumber Planned Parenthood centers now almost 3 to 1 nationwide. So I was, you know, talking to Angela, I'd say we need to develop elective rotations with life-giving alternatives. And this is a critical issue because they are not getting fair and balanced information. And why do I say that? Well, if you're all interested in really understanding the inside of what goes on in Planned Parenthood, read a book called Unplanned by Abby Johnston. Abby Johnston was the director of one in Texas for 8 years. She came into it right out of college with a very idealistic, wanting to help women mentality, and literally stayed in that role for 8 years. She won the Employee of the Year for the Houston umbrella of the centers that were under Houston's aegis as an affiliate of National Planned Parenthood. So she absolutely writes the book from the standpoint of respecting that there are good people on both sides of this issue. That's not the point. But what is the point is she came to convert, partly because of the loving approach of all the people peacefully praying and protesting for her, for all the employees, for all the people coming in and out. They were loving people even after they chose abortion. Literally hundreds of people in the place right next door had not only had an abortion, but then came and got support and counseling from the very centers that would have encouraged them not to have it, but we recognize that we don't have control over people's choices. And ultimately, she was asked by an abortion doctor that came into the center to hold an ultrasound probe so that he could be sure that he was evacuating the baby, and it was a baby at that point. where she could see it on the ultrasound for the first time after 8 years. She'd never witnessed what happened in the womb during an abortion. And as she saw the suction instrument and him move it based on the ultrasound she was holding to try to grab the parts of the baby in the womb, the baby literally trying to move out of the way as she viewed the ultrasound image, she just almost collapsed and literally at one point drops the probe as the reality of what's going on hit her. And it was at the same time that she was getting pressure. She herself, really wanting the best for women, had been trying to encourage people to choose adoption and was getting pressure from Houston to increase the number of abortions. Why? Because it is a profit center, and those procedures are how the income is generated. And if you go into a Planned Parenthood, this is raw statistics, the chance of you adopting the baby out is about 1 in 50 versus having an abortion. So it is not, at least from the people who work in these centers, and she's not the only one who's converted and left the centers who's had this testimony. Carol Nan Everett, who ran 4 of them in Texas. So what you do get from pregnancy resource centers, because they've honed their message over the years to do exactly what Havila mentioned in starting, is asking people how they feel, what are their support systems, what can we do to help you, ranging from finding doctors who can help you with the high-risk pregnancy to finding people who will give away their services if necessary, to finding you baby clothes, to following through if you choose to have an abortion and you need support, because women do. If you don't believe that, there are many books written about this. Real Choices by Frederica Matthews Green is, she makes a metaphor I'll never forget, that women don't choose abortion like you choose between vanilla and chocolate. Women choose abortion like an animal with its leg caught in a trap chews it off. And that's why Real Choices are allowing women to not feel pressured by their employer, by their so-called lover, by their parents who think it's somehow going to delay their college education or whatever else, by a partner that you don't want to be affiliated with. There are other solutions to that problem. So there's a litany of problems that people perceive and feel overwhelmed with. And that's why I think we need to appreciate that. And if you don't go at it the way that Havila and Angela and I'm trying to reinforce, you're essentially, from my point of view, you're being a vending machine, and you're ignoring the wisdom that I've learned over the ages of how blind I was when I was really behaving more like a vending machine rather than a doctor who understands the risk benefits of these different things. And while certain things are legal, the very act of not participating respectfully, lovingly, is a message. And if you aren't willing to send that message, you're essentially, in my mind, looking at myself over the years, I was enabling people. However small, I wasn't taking a stand that this is a line that should not be crossed, where the small and the weak have their lives ended by people who are stronger, and that life is not being ended by choice, not by that life's choice. That's the point. You follow me?
I wanted to just mention something about the power of ultrasound. I think in the case of a woman who comes to me, let's say she has a positive pregnancy test, and you base her LMP, and it's at least 6 weeks, and even before that, I think that if you're skilled in it, to offer her an ultrasound is something that you absolutely need to do if she's thinking about an abortion, because the power of what you see is just amazing. So many women don't realize what is inside them. They are told by the media, they're told by peers or school counselors or whoever it might be that it's not a baby. And I don't think it takes much for a woman to look at the screen and realize that this is alive. And you don't have to be belligerent about it. You can say something like, I'd like to, now that you've had a positive pregnancy test, I'd like to verify that where the pregnancy is, or where the baby is. And doing an ultrasound and then turning the screen and allowing the woman to look, or asking her, would you like to look? And many will. And then they look at it and they see what's inside them, and they're just, something clicks. And so for a lot of women, that will turn the page. I don't know what the statistic is, but I think it's like 70%.
Yeah, it's actually closer to 80, and
Yeah.
Angela's absolutely right on everything she says. And again, the option ought to be there. And fortunately, again, what position does Planned Parenthood take is to fight tooth and nail the opportunity to be transparent about the stage of gestation and the actual product that's in there. It's not a blob of tissue. It's not a product of conception. It's a early human. We call it fetus. That's a Latin for little one. But that's what it is. And you can show these images to 2-year-olds, and they'll look at the screen and they'll say, baby! I mean, it's not rocket science. And that is absolutely part of the hardwiring. It's part of why there literally have been thousands of changed minds, because people have had the option. If there are peer-reviewed studies, what percent of women, if you offered them an ultrasound during pregnancy, just in pregnancy in general, I'm not talking about unplanned, difficult choices, what percent want their ultrasound? 98% would like to have baby pictures. My son, with our latest grandchild, we have 7 kids, 7 grandchildren, thank God, and the latest, one of the gifts he gave his wife was a 4D ultrasound. You know, under the ruse that I said it was a good idea to go get another ultrasound, you know, his father, who's not taking care of her at all, he takes her to one of these folks that actually offers for $200 these unbelievable graphic images, 3-dimensional images of the baby moving. You can see the baby sucking. Some you can actually argue about who the baby looks like more than the other person. I mean, it's absolutely that clear. If you haven't seen those, just Google 4D ultrasound and get those pictures. But that's incredible in terms of a woman's attachment to the unborn life within her. And that's what ought to happen, because what happens if you don't offer that picture is years later they come to realize the stage of development. You haven't been transparent, you haven't told them. And you think about it, what other surgical procedure do you not try to be absolutely as transparent about than this one? And yet we're having this argument nationally over you should do this or not.
And just kind of to reinforce the ultrasound aspect of, you know, the early stages when someone's still really torn up over, you know, whatever it may be, their plans or lack thereof, their relationship with the partner or previous partner. The clinic that Angela is referring to has a few sites, and when they first started, in their first year they had about 60 patients, and over the last 3 or 4 years, they most recently, I think the number that I heard was over 3,000. I went to a fundraiser for it. So it's not just a obscure kind of, you know, couple times, maybe a month or year that you're going to have this situation. Obviously, there's thousands, even in just, you know, suburb or the smaller city of Vancouver. So don't think that it's something that is, you know, maybe less common in your training or practice. Obviously, that's, you know, so many people that are going through that situation, and what an amazing thing to connect someone with that resource. If, you know, then the percentage is about 80 of that person going there, getting the ultrasound, and deciding to keep the baby. It's incredible.
And kind of along the lines of not underestimating the prevalence of this issue. So we're all family doctors, you know, we deal with the whole family, we deal with the moms, babies, everybody in between, but maybe many of you are not going into family medicine or internal medicine or OBGYN. And I just want to share this story. So my husband is a second-year resident here at OHSU, and he's in orthopedics. And for him, we laugh about this because, you know, he went to orthopedics partly so he never has to deal with, you know, talking about this. And I mean, he feels very strongly pro-life, but at the same time, he's thinking that he'll never run into it. Well, he was on the trauma service and as an intern, and this woman, probably young 30s, came in, multiple injuries, multiple fractures, very sick, and she was pregnant. And she didn't know it before, and she found out, when you come into the emergency department, every woman of childbearing age gets a pregnancy test. And Dustin spent a lot of time with her, taking care of her fractures and this trauma, and she came to him, she talked to him one day and was just in distress because the father of the baby either didn't know or wasn't involved. Her parents weren't going to be supportive of this, and she didn't know what to do. And so he was faced with this question as an orthopedist, like, what do I do? I mean, this woman is coming to me and asking, I have to end this. I have to get rid of this. I can't deal with this right now. And so, he tried to offer her support. But so, it's not just family docs. It's emergency doctors. It's the trauma doctor, it's general surgeons, it's everybody.
My first patient as a second-year medical student on the wards was going in to take a history, and while I'm there just beginning the history, I'm only about 5 minutes into it. She's a 23-year-old, I still remember her name is Alma. The oncologist comes and delivers the news that she has cancer. She has Hodgkin's disease. And in 3 minutes, he delivers the news that she has Hodgkin's disease. She's going to have to begin chemotherapy. She's 17 weeks pregnant. I think she's 23 years old. And she needs to have an abortion. And he leaves. The whole interaction took less than 3 minutes. So I'm sitting there as a second-year medical student, and this woman's teary-eyed crying, and I start talking to her, just doing the simple things I do, like, gosh, I'm sorry, and tell me what's going on. And we talked for almost 30 minutes. A nurse comes running in, realizing that the doctor has, experienced nurse comes in and realizes the doctor has unloaded the news and sees that we're actually having a pretty easy chat by that point in time, 30 minutes later, and watches us for about 5 minutes and then leaves and tells me afterward that she'd come in there really nervous that he just dumped all this on her. And of course, she ultimately did have the abortion, but now, what I now know is that actually, by having a mid-trimester abortion, it's actually increased her lifetime risk of breast cancer by even more. So here we are treating one cancer and having some sense of urgency about it, and now we've actually increased your chance of a very common cancer, breast cancer, by the later the abortion, the data shows, the higher the risk of your having breast cancer. And you sort of say, what's the plausible biological mechanism? Well, you're exposed to super physiologic doses of the estradiol and all the other hormones that go up almost 100-fold during pregnancy, which causes proliferation of the breasts. In fact, the very first sign of a woman being pregnant, 2 days, 3 days after conception takes place, is breast tenderness, many days before HCD is positive. You ask any woman who's been through pregnancy, and 9 out of 10 will tell you that. It's a rare woman that doesn't have that sign as one of the earliest signs. So the bottom line is that it's with that proliferation where you have mitoses taking place, where it's most likely to have an aberrant division, and you never get the benefit of proliferation, or differentiation rather, after the proliferation, that makes it form into a functional acinar unit producing milk, and it's the stabilizing plausible mechanism why you do have an overall lifetime decrease in breast cancer. So the bottom line is that I think, knowing what I know now, I would be talking about these things, and I would do the kinds of things that might fly in the face of what advice we gave, 38 years ago when I was a second-year medical student. And I think, again, women are not told these things, and women would make different choices in terms of their own risk, the risk to the baby, that kind of thing, or even carrying the baby to term is the whole issue. And the urgency to start treatment or to use treatments, and I'm not just speaking out of turn. I mean, my wife, as many of you know, has metastatic cancer right now, and you have different options. And some of them are absolutely high risk to babies, and others are less risk, or even almost no risk. And the timing of things is huge in the sense of that. And the urgency is not nearly as great as one thought. And so, and all the organogenesis has happened by what stage? 10, 12 weeks. And then it's just a matter of getting bigger. You're not going to deform organs and things. You follow me? So women ought to be told these things. And it's not just one broad rush. And I think women like that. They like actually being individualized rather than being treated like cattle, like everybody gets exactly the same treatment. So
I want to just address something that was touched on about your experience right now. You guys are in medical school, and it's easy because there's a hierarchy in medicine. Even if you have your own spiritual beliefs and the conviction in your own heart, it's easy to be kind of sucked into the herd, and abortion is presented to people, and it's very prevalent. It would be highly likely that many of your patients will have had an abortion in the past, or that you will be counseling them, as we're referencing. And your experience when the oncologist came in and said, so you have X and you will need to have an abortion. We are all under the influence of seeing our teachers and people who are ahead of us in training give counseling, and also our residency programs, will have abortion clinics that, we may or may not be required to be part of. But it's easy to buy into the fact that it's medicine or that it's a, treatment. But just to give you a sense of how conflicted it still is, just look at all of our pharmaceuticals. There's pregnancy categories for medications. So you could, ironically, be counseling a woman about having an abortion and yet not prescribe her a common cold medication because it's a category, C or D. And so that just shows you that the medical establishment is conflicted. We're not, allowed to prescribe certain medications, or they say use your clinical judgment. If you think a person needs an albuterol inhaler and they're pregnant and it's not, a category A medication, use your clinical judgment. Well, that shows that it's not a rule. There's this idea in medicine that because it's the most prevalent theme is that abortion is a choice, that's something that we will go by, even if in our heart we feel that it's wrong. We maybe can't express that, but it just shows you that the medical establishment is conflicted if you have those discrepancies. So don't be afraid to not buy into it, even though it's hard not to. You'll be pressured by your peers, by people you work with. Sometimes it's not even verbal, it's just the atmosphere.
Yeah, Havelock's touched on something really important. I think what I was also ignorant about as a medical student was that you could think about these things up front and actually check them out. One of the medical students here, I think he's now graduated, but he was concerned about going in an ROB-GYN rotation. I'm a clerkship director. I work with the other clerkship directors, and when he didn't want to be any part of abortions on the OB service here, and he asked me for advice, and I said, well, I would talk up front when you have such strong feelings, and he was not afraid to speak his mind, and he wanted to just have conflict for the sake of conflict. So I wouldn't really encourage you to talk to Meg O'Reilly, who's the current clerkship director, and I think she's a very reasonable person in my experience with her. Just tell her your concerns, and he did, and he was perfectly accepted by her and the rotation, and so that's, I think, the way I would handle it in retrospect. When I was a third-year student, I didn't understand anything what I just said to you. And I remember being on the Old East Hospital rotation, and my eager beaver colleague, I'll call her Mary, it's not really her name, but I'll call her Mary. The one, the kind that always gets the procedures and seems to get people to let her do things. So we're assigned to the guy that's supposed to do second trimester abortions. Now, second trimester abortions are where like the baby's really pretty developed at this point. We're talking like this is recognizable where you can argue about features and who he looks like if you did 4D ultrasound. But in those days we didn't have 4D ultrasound. We didn't even do ultrasound. And it was saline abortions. Saline is where we watched for the first time in our lives, neither of us had ever seen one, the OB resident tap out a fluid packet because we didn't have ultrasound. And then he would clean off the area, put in a large bore needle after numbing up the skin, and pull off some amniotic fluid, confirm he was in the uterus, and then inject 2 ampules, 50 mLs of hypertonic saline into the amniotic sac. Then essentially the procedure's done, and they wheel off the woman. These women were lined up like airplanes ready to taxi and take off on the runway. And there were just really curtains between people and events and that sort of thing. But you know, when that gets done, they're wheeling in the next patient. My eager beaver colleague Mary asked, "Can I do one? Can I try one?" And the resident nods, "Yeah, he'll let her do one." And she goes ahead and repeats the exact same series of steps. And it really doesn't take that long. And that's it. And I'm sitting back in the background watching all this. And then she turned to me and asked, "Well, Bill, why don't you try one?" And you know, I must have had 1,000 thoughts race through my mind at that point. You know, well, she's going to have it done anyhow. I don't want to make a scene. And so I said yes, and went ahead and did what now is one of the most regrettable acts of my life, is to be part of a second trimester abortion. So I share that story not with anything that I like talking about it. I don't, but I do want you to know that you don't have to do that, and you don't need to park your integrity by the door. And had I known what I know now, I would definitely be different. I thank God that I have half my life to make up for the mistakes I made the first half of my life. That's I'll share with you.
Okay, so that kind of relates to the next question, very similar. In 8 weeks, many of us do start rotations in clinics. So what advice do you have regarding this situation, and how do we deal with this when we are under preceptor authority?
I did OHSU training here, so and thankfully, so on my rotation there were 3 of us who were Christians and felt very strongly that we did not want to have anything to do with abortion. And so if you're at OHSU, I don't know how it is at the other hospitals, but there's a gyne service and there's a gyne-onc. And gyne-onc doesn't deal at all with abortions, and the gyne people do. So we all thankfully were able to be in the gyne-onc track, so we didn't even have to deal with it. But and during the OHSU rotation, I believe they do have a session dedicated to discussing this issue and kind of being able to reflect on it. And some of your colleagues will, if not you, will be in the gyne service and will have the opportunity, if you want to call it that, to watch abortions. And I remember some of my colleagues reflecting on it and in kind of a group session, and then being almost surprised at how they reacted, that it wasn't as simple or as cool, or I don't know if they even call it cool, but just straightforward or as emotionless as people like to make it. And I think that it'll be a tremendous opportunity for you to lovingly share with your colleagues. And it may not even be sharing with them, but even asking them questions about how they feel about their experiences, because some of your colleagues may not know how they feel about this issue. They may kind of have this idea of choice, and it's just about choice, and not really even understand the implications of what that means. And so I think that during your third year rotation, you absolutely do not have to be involved with that if you don't want to be. And you'll have the opportunity to kind of reflect with your colleagues and kind of debrief about those experiences. And I think it's, if you know where you stand, I think it's important to help your colleagues process their experiences and maybe even come to some different conclusions than they started out medical school with.
Yeah, Well, it's so prevalent to want to be politically correct, you know, even if your friends that are secular know that you're a Christian and that you have certain beliefs, it's still it's not the politically correct stance to have. So I think it's easy to want to be there step by step and maybe plan in your head, oh, I will, you know, I just won't, you know, do X. But I need to learn this because this is medicine and this is part of medical school. But it's okay to not, and to remove yourself from situations, or to be really forthright with coordinators, directors about how you don't want to be involved in that. And the Lord will honor that if you, you know, if you present it to the Lord in that way, as far as, you know, here's a situation, I'm afraid that you know, it could be anything as simple as what people think of me, to whether my colleagues respect me, to whether I'll be able to make it through this rotation and, you know, pass or whatever. But the Lord will honor that that decision, and you won't regret it. You may regret, you know, just kind of floating through or doing most things, and in your heart knowing that it's not the best thing or right thing, but you won't ever regret just not being in that situation. And so I think it's important to be really clear with, you know, during those rotations.
Havel's absolutely right, and the impact you have even on the clerks of director is important. You know, you don't think you think you're the learner. I remember part of what caused me to consider my habit and behavior. You know, as a resident, I put in dozens, scores of IUDs, and it was a medical student, ultimately a resident, who came visit me in Sweet Home, Oregon. They asked me the question, well, Bill, how do you feel about IUDs? And I knew he was a very strong Catholic, and he knew where I stood in terms of my faith, and I knew what he was getting at, just asking the question. What was he getting at? The mechanism of action of IUDs. Now, at the time, we had fewer choices. Well, actually, had more choices. They had Lippy's loop, which is an inert piece of nylon, and all it does is sit in the womb. So the only way it could act is what? Interfering with implantation after conception takes place. So he's asking me, what am I doing, and how can I reconcile what he knew was my belief in pro-life causes and things with the whole concept of IUDs? And I remember my answer was something along the lines of, you know, I don't know, it's kind of too small, and I'm not really trying to, and it's kind of passive. I didn't even finish my sentences, as I recall, and I just couldn't make a coherent thought in defense of my behavior. Well, I didn't stop that day, but here I'm telling you about the question, just a simple question, by a discerning young Christian who didn't want to conflict himself with things, and he thought things through more than I had at the time he asked me the question. And then finally, you know, it was at a time where IUDs were really not doing so well, and one of the OBGYNs in the area, not over life issues, but just over infection and harm to women issues, had decided to stop using IUDs. And he was talking about it at a conference in front of 50 doctors. And it was a breath of fresh air, because between the question by the learner who came to learn from me and the OBGYN who just stopped doing it in his practice, I decided to stop doing them, you know? It was the two. And, you know, I've made a lot more progress since then in terms of understanding life issues and the whole field of family planning and so-called contraception, because sometimes it doesn't prevent conception. You know, I'm on the Physicians Advisory Council for Focus on the Family. I've been there for 15 years, go twice a year. I've been there every year except for the year my dad died about 9 years ago, and missed that meeting. But we have argued, including the most recent meeting just 2 weeks ago, about the mechanism of action of birth control pills. Anybody know what I'm talking about? What are the three different ways, the primary ways that birth control pills might act? Suppress ovulation, change the cervical mucus so that you don't have these nice microtubule swimming channels like you get under electron microscopy, and thinning the lining of the womb. When you're on birth control pills, what happens to your periods generally? They get lighter, shorter, and it doesn't enhance the landing site, if you will, for the conception. Can conceptions take place in unfavorable landing sites? Sure. Tubes. But if you're an infertility doctor, one of the things they try to do is make sure that your lining of your womb is at least 7 or 8 millimeters thick. So we want women, at least I think what we've come to is consensus after years, literally years of discussing this issue and how do you inform women who care about post-conception effects, said, well, earnest doctors disagree about this, pro-life doctors. But there's some, like me, who have concerns about that third effect, that in some women, in some cycles, the mechanism of action is actually abortifacient. So you have to tell people these things, and I've told people, in fact, talk about fears of like medical students. So I was in practice, and I came to hear a group of people talk about this issue over 3 days, and within a half a day I realized they had a real point to make. And the next 2.5 days, I didn't need more information. I was sweating bullets because I was an associate professor at the time. I had 7 kids to raise and feed, and my entire life was teaching medical students, residents, seeing patients, and doing all these things. And I'm trying to decide, what do I do with this? Do I keep doing it? Because I cared about post-conception kind of things. So I didn't tell my wife because I was afraid that if I told her about this, that she might hold my hand to the fire and I have to do it before I was ready to do it, And but I did tell the front desk that I wasn't doing this anymore. People came in for contraception. I wasn't going to be doing it because I was concerned about that third effect. Now, some of my colleagues, I'm not getting into the content of this thing. I'm just telling you, once you yourself believe something's an issue, then you got to decide. I decided. The very first woman I had that snuck past the front desk filter, because there's old paper charts, P&P, pap and pelvic, and VCP, birth control pills. And so I'm thinking, oh my gosh, I got to talk about this now. And so I go in and I take the history, and sure enough, she wants to have pap and pelvic and birth control pills. I go ahead and do all the history, do the pelvic, get done. And then I said, well, I understand you want to have birth control pills. And she said, yes. I said, are you aware of your other options? Kind of like talking about abortion. Are you aware of your other options? And she rattled off a couple, and I told her a few more. But I could see the glazed over look like she'd made up her mind. And I said, well, had you come to me 3 weeks ago, I would have just taken out a pad and had written a prescription. But this is not a reflection on you or your decisions. You can do what you want. But I personally made a decision not to do this, and there's no charge for this visit if you're upset and you had an expectation. And she said, well, why have you stopped? And I said, well, it's a personal decision I made. I just don't want to be involved in this anymore. And the more I tried to protest and tell her I didn't want to talk about it, the more she wanted to know. So I finally said, well, I will tell you if you want to know, but it's not because I'm trying to judge people who make this choice. And I went through all this legal preamble, And she said, no, I want to know. So I went through the 3 things. I talked about medical issues only. I didn't talk anything about my own faith, and all that was troubling me too. But I talked about, it inhibits ovulation, and it changes cervical mucus, but it also might thin the lining of the womb after conception's already taken. And she interrupted me. She said, well, you mean it'd be like an abortion? And I said, well, I wouldn't have used that word, but yes, I guess in essence it's stopping the implantation, a successful continuation of that conception that's already taken place. And then she said, well, I'm glad you told me that. I would never want to do anything that might cause an abortion. And so I kind of waved, the sweat off my brow, and I said, well, I just want you to know I wasn't trying to judge. No, I'm glad you told me that, is what she said. Now, there are people, doctors, good doctors, who disagree with what I just said. But there are also lots of doctors who thought about it and agree with what I said. If you go to the American Association of Pro-Life OBGYNs, you'll see a treatise of the peer-reviewed literature that supports my point of view that I'm concerned. And there's a bunch of peer-reviewed literature that supports the other point of view. My point in sharing this story, though, is that you can go wherever you need to go with your integrity, and I think you shouldn't violate it. And that's very different when I was a resident. I remember somebody, over the issue of referral that Angela brought up, was arguing with one of my attendings, who ended up being the chair of the University of Washington's Family Medicine Department, the attending did. And I remember sympathizing with the attending who thought we all should just be professional and do whatever's legal, including refer. And I was thinking the resident was kind of being rigid, and then I recognized in retrospect, you know, the resident, I think, was absolutely right, and the attending needed to learn from his resident about, you know, you don't want to ever violate your own integrity, your conscience, or park your beliefs by the door. You are not vending machines. And that is something that is hard fought right, and we don't want to lose that in this country. And I'd like you all to, if you took nothing else away from tonight, that's important, all right?
All right, I just wanted to open it up for questions. I want to leave ample time for people to ask questions on the panel. So if anyone has any, please ask.
I have a question. I'm not a medical student, but I often hear the other side arguing that there's a pro-abortion, and there's obviously an uncountable number of specific cases, but where if the woman's a victim of rape, where if the baby has Down syndrome, and in that case, and the woman's very, you know, she wants to have an abortion. How do you talk with that?
Good question.
So the question for everybody here was if a woman is a victim of rape, or if she has a baby with a severe malformation or Down syndrome, and she wants to have an abortion, what? How do we? And they're convinced. How do we deal with that? So who wants to take that?
I think it's the same way. I mean, a family who, for example, had a wanted pregnancy, a planned pregnancy, and then has the, you know, they get the ultrasound and find that they have spina bifida or anencephaly, or they have, you know, they get the quad screen and they're at increased risk for Down syndrome. And even if you have a family that you're just even counseling for some of those genetic things, I think you still have to approach them and care about the mom, care about the baby, and acknowledge the difficulty of this decision and empathize with the patient and their family that this is very difficult, and this is going to be a difficult pregnancy, or this is going to be a challenging situation. You will have lots of, you know, whether OBGYNs or maternal fetal medicine or family doctors who will just automatically offer that and say you can have an abortion and whatnot. But I think you still have to take the same approach of asking the patient how they feel, because they might be devastated. They wanted to have this pregnancy, and now a doctor is telling them they wanted to have this baby, and a doctor's telling them that that they should have an abortion because this baby's going to die.
They may even encourage.
They may even encourage it.
That the doctor almost has a projection of his or her own belief in the situation, that they'd be better off aborting the baby and starting over fresh, so to speak.
Yeah. The point about rape is a really good one, and I've had actually a couple of patients who have had that experience, and the first thing to do is just, you know, acknowledge that it obviously must have been such a traumatic experience. And then the second thing that I found really just covering of the situation was addressing the point about how women who choose abortion end up feeling actually violated sometimes, and they feel that they lost control of their body at that point during the abortion. They dealt with a lot of guilt. Statistically, there's a lot of guilt and depression associated with it. There's medical problems associated with it. So what I just tried to kind of have them come to, you know, without directly saying it as the right way or the only choice was to not have an abortion, but just have them realize that it's not gonna heal. That getting an abortion is a trauma actually, and it's not gonna heal a previous trauma, which is a rape, and they might actually amplify it by
That's an incredibly important point. I mean, the mythology is that the abortion puts everything behind, and so you can never forget the rape. You can't. It's an incredible violation. And then the solution of the rape, the idea that ending the life of the innocent life that was the product of that rape is somehow a solution is absolutely unproven in some inflation. You start out, just as Angela said, you know, you have to empathize with this horrible situation, whether it's a date rape or it's whatever else. These are not uncommon events. They are uncommon in terms of cause for abortion, like less than 1%. You have to keep it in perspective when you hear those questions in the political aisle. This morning I was, after church and coffee and donuts, I was holding a Down syndrome baby on my lap. The family, like your family, had at least 9 kids, I think. I've lost count. And this latest one is this adorable child that has Down syndrome. Of course, I didn't have her on my lap long before one of the other siblings grabbed her and ran off with her. You know, that is the most loved child you can imagine. Now, the sad truth is that you can react to a child that has a disability in different ways. You can say, like some in the culture would say, that that's a life not worth living, that it has no value, that we ought to search and destroy them. Those are harsh terms. They were used in Vietnam as a tactic militarily. But literally we had a Surgeon General of the United States of America who was celebrating that we have fewer Down syndrome babies now, and the only reason we have fewer is because we do the quad screen, the triple screen, or the ultrasounds, or whatever we do. And when that happens, there are literally people who say you'd be better off having an abortion, unlike these parents. So in my parish, we have 2 kids with Down syndrome, and again, they are the most loved kids. And the other thing about Down syndrome, if you know anything about them, not only the support groups and the things that are available, but they aren't depressed kids. They are happy. The families that have loved them and engaged with them and recognize what a blessing they have. So part of it is helping a person come to grips with it. In some cases, when I have a patient with a certain malady and I know I have another patient that has a similar malady, I try to get the 2 of them together. Would you mind reaching out to this person? Would you mind if I have so-and-so give you a call? And I never had anybody turn me down in my 30-plus years of experience of trying to get people. And it just changes everything when somebody who's not talking theoretically comes into their lives. And I think that's what we ought to do as doctors, is recognize that we got a challenge to deal with. But the idea of saying it's overwhelming is unfortunate. So, you know, the rape, I mean, one of my daughters, you know, have all striven to be abstinent until marriage. One of them got date raped, you know. So what I do, I mean, I support the heck out of her. If she had a pregnancy, I'd feel blessed. It's all an attitudinal thing. Now, how do you get people to change those attitudes? Well, I mean, the hardest case I can remember dealing with, and somebody coming to me post bad outcomes, she got anencephaly diagnosed in Corvallis. She'd gone to a crisis pregnancy center. The crisis pregnancy center, that was what it was called at the time, had a doctor that suggested, because it was anencephaly, that she come up to Portland and have an abortion. So the pro-life director of that clinic knew me and called me and said, would I mind intercepting them if they would stop by my office here at Emma Jones Hall when we still saw patients here? And I said, sure, I'll do it. So on the way here, with the father of the baby, which is unusual, he was with her. And her biological mother was with her, and also an adopted mother. This is a kind of convoluted family, but 4 of them are in the office with me. And I start out, I want to be honest with where I'm coming. I believe, you know, I want you to know I'm here, and I'm here to support you, but I'm also here to find options that will support your baby, and that's my point of view. I believe both of you are important. I want them to know where I'm coming from. I don't want to have any kind of hidden agenda. And you can reject my advice, that's your choice, but I want you to know this is a different point of view. And I said, you know, anencephaly doesn't require abortion. And I know with the data that I just shared with you about you're actually healthier carrying a baby to term. And I've had to argue with some of my OB/GYN colleagues about that point, because they literally will tell a woman that she's better off, and going through labor and all that's going to be difficult and all. Well, I spent 45 minutes at least, maybe an hour with the 4 of them, getting everybody to express their point of view. I was kind of astonished that the father of the baby actually was supportive and said, I'd like her to keep the baby. The mother was really ambivalent. The adoptive mother was not yet involved very much. And then the natural mother, who really wasn't where the woman resided, that woman who was pregnant, she weighed in only reluctantly, because I had to get out my pliers and say, you know, what do you really think? Because she initially said, well, it's whatever she wants. And I said, but I want to know, you're the grandmother. What do you think? What's your thoughts? How do you feel? And the mother of the baby with the anencephaly finally says, yeah, Mom, I'd like to know what you think. And she, out of her mouth, goes, well, I'd keep the baby. And you could see the impact it had on her daughter. And they left. I had no idea what choice they would make. I didn't hear anything more until about 4 or 5 months later. I got a note from one of those mothers. I don't know at this point which one it was. But they talked about the baby had delivered. She had ultimately chosen to keep it. Oh, by the way, I also told them and said, look, it's okay for you two who know her best to express your point of view. You know, being neutral is really not compassionate. It's apathetic. Whatever you do doesn't matter to me. Have you ever heard that before? I mean, it's like, it's not weighing in. You do care. We're not islands. We affect one another. So, at any rate, the bottom line is, I get this note back. It's a nice little note thanking me for the input that the baby had been born. The baby lived for 45 minutes. They put a little hat on the anencephalic head where made the baby look pretty normal. The baby was christened, named. They were able to love the baby for 45 minutes and say goodbye. And they buried the baby. There was closure to a difficult event. And now, I'll quiz you all. Is the mother healthier or less healthy? What's the answer? She's healthier from her breast point of view, and she's healthier emotionally. She has no second thoughts about, did I do something to interrupt the life just because it was disabled, severely disabled? And she has no second guessing. And do people have this? I mean, just this week, one of my patients I've seen for years, I'm going through that usual history of sexual history and how many partners have you had. And, you know, I'm going to pause, and then she tells me in double digits. And then I say, and I go through her obstetric history, and you've had 2 abortions, is that right? And there's a pause. And I said, was it more? Another pause. Well, I haven't really told anyone. She's 50 years old. And I just said, well, I just want to know from the standpoint of health risk, that's all. Another pause. And she said 10. And if you don't think that's relating to the other psychosomatic issues that she has in her life, we're acting like we're robots. Of course it has an impact. And so I just have found my practice so much fuller as I've gotten engaged with people's lives, and I've gotten engaged to share that I care about them, I care about the babies, I want to help them, and I don't want to do what's seemingly politically correct. By the way, you're right, it is politically correct in a university environment, but nationally, 52% of the population now, in fact, Gallup polls, can self-professes themselves to be pro-life. So apart from university systems and medical schools, you aren't being politically incorrect. You're actually in the majority, or the near majority, whatever, depending on the year of the poll. So Hal was right that in your environment, in medicine, we're a little bit of a skewed population that unfortunately is not reflecting the national psyche anymore. Well, I should say, it's good the national psyche is changing, but the medical school psyche is going to depend on all of you in this room in the future, I think. Yeah. Why do I create this silence every time?
Other questions?
What are
Bethany?
your suggestions in speaking with women who have had abortions in the past? What sort of advice do they offer?
So I don't know what your experience has been, but in family medicine we deal a lot with depression and anxiety, and after rotating at Options 360, I find that I'm thinking about it a lot more when I am assessing a woman for depression, asking her more about her history, and if she's, you know, or at least I'm thinking about it, if she's had an abortion in the past, how she feels about it, and trying to ask her, you know, if she thinks it has an impact at all on what is going on. And a lot of times it's asking good questions of your patients to help them come to whatever conclusion potentially or I have asked a woman this before who had depression, and how she felt about her previous abortion, and if she thought it impacted what was going on in her life and the stress that she was experiencing with relationships. And she said yes. And so then you can offer resources. There are post-abortion counseling groups, some of them through churches. The Pregnancy Resource Center offers a post-abortion support group. There's some local churches in Vancouver that offer them as well. So when you are able to help them realize that this may be an issue, then you can help them heal and help them find the resources to help them heal.
There's an organization called Project Rachel, the Rachel taken from the Bible of Rachel, no more children and weeping and like that phrase. And there's a book called Forbidden Grief by Teresa, I always block on her last name. Forbidden Grief is the book, and it's a very telling expose on really what is in the hearts of people who felt like had no choice and made a choice that they often come to regret. Now, it's not everybody. That's the other part, is that I'm not trying to get people to feel grief and guilt if that's not where they are. But the point is that by asking those questions, you find it is far more common than not. I won't mention doctors' names, but there are doctors here who tell students that they themselves had an abortion and never looked back, and that was the greatest thing that happened to them. You know, that's they're right here on the faculty. So I'm not trying to debate somebody's personal testimony about how it perceived them, but they do not reflect the majority of women based on all of these focus groups and the documentation from people like Frederica Screen and Teresa, whatever her last name is. Nobody can help me with that, but nobody's read the book. It is worth getting. If you just look at Forbidden Grief as a Google search, you'll find it. They're really worth reading because it gets at, how do you respond to people? Because here are people who do this professionally, and they're actually talking to the women and sharing it in a very lived experience. So I really highly recommend those things to you.
I'd like to comment on the resources for women who are having post-traumatic stress with abortion. I worked with Pregnancy Resource Center, it was Crisis Pregnancy Center at the time, for several years counseling. I started out doing things there, but I felt like what I wanted to do was really participate in the new ministry they had at that time, which was called HEART, Healing and Encouragement for Abortion. They still are doing those 12-week studies. They also have a separate one for men called A Father's Heart, because women are not the only ones who suffer trauma from abortion. Men do as well. I have resources here for people if they want to. There is a number for the Pregnancy Resource Center of Portland. It's called the 503-22-HEART. And that they also have a website called portlandheart.org. And there are groups that are available at all the 5 resource centers. I've done this myself. I've taken women through, and they have believers and non-believers. It's a biblically based course, but there are women who have encountered God and received healing and have accepted Christ and have been delivered. And so that's where maybe it's not something that you're going to have right now in clinic, but we may have friends, personal friends, who childhood friends who've had abortion and have never, ever. It surfaces, the pain surfaces, and then it goes underneath. Yeah. But there are places where if women are feeling that pain, if they are feeling that depression, if they're feeling suicidal and suffering, that they can get help. And that's a window of time where the Holy Spirit comes and opens their heart, and they can actually connect that there is something going on that we need to do. And so that's a very pivotal time. It's excellent. So
Thanks for sharing that. It's important that while you were talking too, and it is a huge hole in people's lives. And the book is by Teresa Burke. And part of how she came to it was exactly like you said. She was actually a psychologist in training, and she was doing a women's obesity group. And somebody in the obesity group talked about how some of her eating, or the whole point of what's going on in her was her abortion. And that caused a ping pong in the group, where many other people admitted that that was a big hurt and a hole in their lives. Another person in the group got real defensive about, why are we talking about this? There's no big deal with this. Someone else in the group ran out of the room. And she goes and relates this to her supervising counselor, who wants to have her push it all under the rug and say, don't ever bring that up again. And she said, I didn't bring it up. They brought it up. And she literally talked about that forbidden grief was that women weren't allowed to talk about it. The counselor didn't want her to talk about it because it wasn't politically appropriate to say that abortion had some sequelae. And it's just a real interesting lived experience of somebody who's now become an expert, as you have, in helping people to relive and regain who they are because of the deep hurt, the post-trauma of this. And I think we need to be sensitive, and I think that's the way, I heard both Pamela and Angela start out, is that, look, I'm not here to judge people. I've shared with you, I've made some big mistakes in my life. And that is not what I'm about. But on the other hand, to ignore the reality, the lived reality of women, and not help them or men is I think, a tragedy, and it's unscientific.
It helps them also for the women to acknowledge that it really was a fact. That there really was a fact. And at the very end, they have an opportunity to actually ask the Holy Spirit for the sex of the child and anything. And as you said, before, brings more trauma to have one taken and to deny that it was taken, or to acknowledge that life was taken and it
it's interesting irony, as you were talking, I was also thinking about, there was a former chair of OB/GYN who's now retired, Paul Kirk, and one of the things I think he did very nicely was to get a support group for people who had lost pregnancies, miscarriages. So isn't it astonishing that you'll get acknowledgement of the grief? My wife and I have been blessed with 7 kids. I told you we also experienced 7 miscarriages, especially as you get past your prime, which I am, and your likelihood of miscarriage goes up as one gets older. Just Shannon, when we had our 5th child, I was getting a little nervous as a parent. I was thinking, well, menopause doesn't happen sometimes until 55. We keep up this pace, we're going to have 15 kids, ignoring the fact that you get down to single digits pretty quickly after you turn 40. And then, the issue of can you hold a pregnancy becomes harder as your hormonal levels drop off, male and female and the like. And so, we did experience the grief. And I don't think a man has quite the hurt in general. I didn't really understand. I also came from that fearful place of what am I going to do here with 15 kids to realizing what a blessing they were, and I'm not going to get 15 kids. And then grieving with my wife, but not in the same way. How could I possibly understand the loss of somebody who has the baby inside them for months and then loses it? I don't think there's any way I would ever say, I understand what you're going through. It's not something you'll hear this male voice say. So.
A question about resources. So clinics, they stock up on things like do it yourself, PT, physical therapy, and clinicians usually have a set of folders for every scenario to attach to the visit summary. Is there any standardized version of the resources you just described that's fairly pamphlet, something that clinicians the clinics can stash in their practice? For example, if Providence has a Christian film, I don't understand the origin of it, but they seem to have Christian motifs on posters on one of their clinics.
They seem to have what?
Christian motifs on their.
Like tribal religion.
Yeah, actually, I don't know what the origin of Providence as a healthcare institution is, but I mean, there are practitioners that may be favorable for these.
Right. So your point's very well taken. So you're asking about resources, and I'll let Angela and Havilah, because they're closer to these different systems than I am familiar with some of them. We used to be at Providence, Milwaukee. By the way, Providence got started by sisters coming over on mules who actually wanted to serve the underserved, and that was part of their whole reason for being. It's a great history of that. If you go over to St. Vincent's and look at some of the pictures and memorabilia, it's an interesting story. In the 19th century, these brave women were the genesis of Providence. Providence Northwest is a huge hospital conglomerate. You got Providence Portland, you got Providence Milwaukee, whatever else. But you also had an important insight in that they're not carbon copies of all the doctors there. There's some doctors who practice in these things, institutions, as my colleague in internal medicine, Chuck Bentz at Providence St. Vincent's, found out, that are pro-assisted suicide. He refers a patient for oncology to one of his, patient with recurrence of her cancer to an oncologist, and gets, instead of a recommendation about treatment, would you be the second signature on a assisted suicide request? And he was just devastated, shocked. That ultimately left to his resigning from Providence St. Vincent's, as they basically, instead of supporting him, actually attacked him for his having stood up for his own belief system that assisted suicide shouldn't be going on in that Catholic hospital system. So, you can't just assume because the trappings say this that the individual doctors are going to be there. I remember trying to, after I delivered a baby, we used to deliver babies at Providence Milwaukee as a way to boost the number of OBs our residents got. And I remember delivering a baby, and it was a Hispanic couple, and I talked to them about options for spacing children, including natural family planning. How many of you heard an attending at OHSU ever talk about natural family planning?
Midwife.
You heard a midwife, okay, and that I could be an attending. Well, thank God there's at least one. But the point is that it is an option if you actually do peer-reviewed articles and tell women about it as an option. Almost 70% of women in this one study would like to hear about it. 40% would actually like to try it. That's the science, that's the data in published peer-reviewed studies. And yet we're silent about it. It costs nothing except the time to learn, and the charge if you go to a formal course, it's about $110 online. Northwest Family Services, that's one of the options. But the reason why I thought about this was I went to the front desk to say, could you give me some information about natural family planning options for this couple? And the nurses looked at me puzzled, like, what are you talking about in a Catholic hospital system? And I had to go to the computer myself, go to nwfs.org, northwestfamilyservices.org, homepage, click on couples and singles. Next click, go to natural family planning, and I printed out about 5 or 6 sheets. And I gave it to them. The couple was interested in it. And for all I know, they're still using that method, which is highly reliable. Even in third world countries, it's over 95% reliable in preventing pregnancy. It's the only one that can be used both to prevent pregnancy and to enhance your chance of getting pregnant when you want to. If you're a normal couple, you have about a 95% chance of conceiving in 3 months if you use natural family planning. In other words, you time intimacy with your partner at the same time that you're fertile. And you use all of the natural physiologic signs that tell you you're fertile. And so it's just breathtaking that you can't get even resources sometimes in a system where you think you'd want them. You mentioned, Pregnancy Resource Centers is a great resource for people looking at options. There's Stand Up Girl that is supported by Oregon Right to Life. It's worldwide. It gets millions of hits. Part of why it gets so many hits is because we actually contribute and donate to get the Google and the search engines to actually bring it up above others. So it'll generally show up in the top 10 hits. And it's other women facing difficult choices that they can actually not only look at examples and stories, but they're literally, this woman, Becky, Canadian citizen started this thing about 10 years ago, and now they have got the equivalents all over the world, and it's a great resource of things. So I don't think I can think of one source of these things. You have to, I would write down those websites, you know, the Pregnancy Resource Centers of Portland. I would write down the Northwest Family Services as a .org. It has great resources not only for couples, singles, for people who want to have strong relationships, and they've been around for 30 years. I also disclose I'm on the board of directors for that group as well. There's the Pregnancy Resource Centers in Vancouver. Other options that you brought with you?
I did bring just a couple of samples of some of the things that the Pregnancy Resource Center carried that I thought were really good, and I think they're put out by Focus on the Family. So that might be a website to check out. Right now when I'm in practice in the residency clinic, I'm not organized enough to have all of stacks of papers that I give to patients yet. But I think when I get into practice, I'm gonna try to get these resources so that I have them available. Some of these good brochures that like Focus on the Family puts out.
Focus on the Family is FOTF.org. It's that simple. FocusOnTheFamily.org. And then it goes in a zillion directions. They're more than happy to help you. You just call up and say, I'm lost, I need a resource. They're in Colorado Springs, but they free phone calls and 800 lines and all other resources happen.
Well, I think just in general, there's lots of resources, and they may even be different when you're practicing. But one of the best things is to have a some sort of personal connection, if not that you know a person that works there, or even the address. I know it sounds funny, but think about if you need something and someone tells you, oh, I've been there, it's a great place. How much of a difference that can make versus just a sheet with 10 choices, and then they kind of feel, well, I don't know, still feel a little bit lost. So it's nice, like Angela has the experience from being at the one of the option centers, and I know a couple of people at different places, so I can't tell you how much of a difference it makes for a patient when you say, wow, I really like so-and-so, they're actually there, I think it would be a great place for you. And so it's your patient, they're coming to you for the best care of them, and you've probably built up some trust with them, and so it makes a big difference if you have a some sort of reference, or it doesn't have to be personal, like you've worked there, and you don't need to know someone there, but even just like I said, the address, or it's easy, where do you live? I know X is pretty close to where you are, and then that can change life, obviously.
It's a great point. There are people like Steve Baker and others who've been around for a long time. We're usually flattered to be asked to try to help you with these kind of issues. So you can Toffler.at ohsu.edu. You can do these things, and we've been through around the track often with these issues. The APLOG is another organization. I used their website when I was at Focus, we come up with better references than we had in our statement about the yin and the yang of contraception. And so APLOG, American Association of Pro-Life OB-GYNs, and I think that's just their website address as well. But or you just Google American Association of Pro-Life OB-GYNs. And so, use the telephone research. That's what I do in practice. If I don't know something about an arcane aspect of endocrinology, I'll call up, if it's osteoporosis, McClung downtown, or I'll call up Lynn Lorio. And they're usually flattered to be asked. They know the stuff, or hematology, Delorio. And when it comes to life issues, I don't think there's any area yet that I haven't had a chance to at least be very active in, if not study in depth. And so I'm glad to help. As I say, to me it's exciting. It's really exciting to have so many people here on a beautiful day talking about these issues. And I can't think of anything more important that we could be discussing than the next generation and how you all hold your integrity against the cultures trying to erode it. Keep your faith to yourself. Okay, practice your religion in your church, but don't talk about it in the public square. And that's where we are. And I think this gives me great hope.
Well, thank you everyone for coming. Actually, we are running out of time. But I just want to thank also Autumn and Bethany. They've done a lot of work helping get this together. And let's give our panel a big round of applause. And if you guys have any questions, please come up and ask the panel
I had some.
briefly at the end. Yes, and
Yes,
John would like to have some.
you asked for referrals. Med Students for Life can provide you with a referral sheet for this area. So if any of you need referral sheets, we have them. They'll give you every pro-life specialist and doctor in the Clark County and Multnomah County area. So
Yeah, and Oregon Right to Life has a website too, ortl.org. Catholic Medical Association has a website, cathmed.org, I think it is. The CMDA, I mean, all of these folks are involved heavily in these issues and have been for years, and so I appreciate your getting us all here, John.
yeah, thanks for having us.
Thank you, everyone.